Very good morning to all the people who are here, and welcome to this hall and this session. And we are today going to talk about, basically we wish to prevent a disease which has got irreversible damage. So the faculty is extremely good, and we'll be talking about are we doing enough for glaucoma awareness and screening. So we'll have 5 speakers. First speaker will be Dr. Pawan Kumar. He'll be talking about the awareness, the novel ways of awareness. I'll be talking about the glaucoma screening, is it viable in the community? After that, Mona will talk about opportunistic screening, and Dr. Nikhil will be speaking about LVP way. And in the end, Dr. Venkatesh will tell you what can AI do towards this detection of glaucoma in the entire community and everywhere. Like what role can AI play? So we'll start with Dr. Pawan Kumar. Pawan, may I have you?
Yes, madam. Good morning, everybody. I thank Madam and Dr. Venkatesh sir for giving me this wonderful opportunity. The topic of discussion for me is how do we do glaucoma awareness in a creative way. So normally in the first or second week of the March, we celebrate as a glaucoma awareness week, where we do various activities. So we do a walkathon, or we do some doctors and the staff of the hospital, they just walk around the street creating awareness, or people who come to the hospital, we just display some posters. So all these things will create awareness for sure, but how much is it going to retain with the people who get exposed to that? So all the years we were doing the same work in our hospital, and we thought in 2018, we thought, why don't we try it in a new way, where people get to know about awareness, and it should last for more time than what it usually lasts for few days. So for that, we arranged a special program, which I'm going to talk about it today. So, yeah, all of us know that the glaucoma is the second leading cause of blindness worldwide, and the estimated glaucoma prevalence by 2040 is about 112 million. So the burden of the glaucoma is mainly because it is not easily available for diagnosis, and mostly the glaucoma is asymptomatic. There's a very poor awareness in the society. About 50 to 90% of the glaucoma in the society remains undiagnosed. So early detection is the key. So early diagnosis intervention reduces the risk of glaucoma blindness. It preserves the quality of life, and creating awareness and adherence to medication leads to reduced need for surgical intervention. So as I discussed before, this is a video of what we did in 2018 and 2019, and we're still continuing the same. The audio is not coming. So this is a special program. What we did is known as a 3D click art exhibition. So the 3Ds, we asked the help of the local artist to draw various 3D pictures, and then we started exhibiting that along with the glaucoma messages.
Glaucoma is the second leading cause of blindness worldwide. More than 65 million people worldwide are estimated to be currently affected by glaucoma. By 2040, it is estimated that this number will reach 112 million. Glaucoma accounts for about 5.8% of the overall burden of preventable blindness in India. Infamously known as the silent thief of sight, glaucoma remains asymptomatic until the last stage. Awareness about glaucoma in India is very low, and ranges between 0.27% to 13.3%. Glaucoma-related blindness can be prevented if the disease is detected and treated early. Early detection can be achieved through effective screening. The success of screening programs requires the participation of the general population in large numbers, which is not possible without some degree of awareness about the disease and its blinding consequences. Therefore, attempts to reduce the burden of disease will be unfruitful without improving awareness among the general population. Every year, the second week of March is dedicated by the World Glaucoma Association as World Glaucoma Week. A wide range of publicity-attracting activities happen around the world during this week to create awareness about the disease and encourage periodic eye checkups. The various activities that happen during this week include poster displays in clinics, utilizing mass media such as radio, television, or newspaper by giving public talks on glaucoma, conducting a walkathon, and encouraging already diagnosed glaucoma patients to spread the word about the disease among their families. Every year during the period of World Glaucoma Week, we conduct all these various glaucoma awareness activities. Even though these programs are effective at creating some awareness of glaucoma, the impact is short-lived. In the years 2018 and 2019, we decided to conduct our glaucoma awareness program in a unique way. Pondicherry is a favorite destination for tourism, and its seashore is the main tourist attraction. We planned and designed a 3D click art museum cum exhibition as a glaucoma awareness promotion platform. With the help of local painting artists, various pictures and models were created as 3D pictures. These paintings were made of eco-friendly material or recycled waste materials. These were designed to look visually attractive while spreading awareness about the nature of glaucoma and its consequences. The exhibition was open to the public without any entrance fee, and a team from the hospital, led by an ophthalmologist, was present throughout the day to explain the disease. In 2019, we started screening the visitors for glaucoma who were above 40 years old and willing to undergo examination. Intraocular pressure was measured using handheld rebound tonometry. Optic nerve examination was done through a fundus photograph. Patients identified as glaucoma suspects underwent a quick visual field examination in a portable, virtual reality-based perimeter. Glaucoma suspects were referred to the base hospital and offered a free eye checkup. We also analyzed the impact of the exhibition in terms of creating knowledge about glaucoma. Visitors were invited to complete a questionnaire with 10 questions to assess their knowledge that they gained from the exhibition. Those who answered 8 or more questions correctly were given a plant sapling as a reward. Approximately 1 lakh people visited the exhibition each year. 2,198 people were screened for glaucoma. 106 people were identified as glaucoma suspects and referred to the hospital. 12 of them were found to have an advanced form of glaucoma. 545 people participated in answering the questionnaire. People from age 10 years up to 87 years completed the questionnaire. 74% were male and 26% were female. 78% of them were either graduates or listed below graduation as their education status, whereas 22% had done postgraduate studies. 85% were from Pondicherry State and 15% were from other states. 50.1% had answered 8 or more out of 10 questions correctly. 58% of people were able to identify glaucoma as a condition with raised intraocular pressure. 74% understood that glaucoma is not contagious, and 83.4% of people were convinced that eye checkups are needed for all above 40 years of age. 50% recognized that screening family members is essential, and 68% became aware that vision loss due to glaucoma is irreversible. People who attended the exhibition were very excited to see the artwork and took selfies and group photographs. These photos will remain as lifelong memories and also keep spreading the message about glaucoma. Through creating awareness about glaucoma, we move one step closer to conquering glaucoma blindness.
So by making this exhibition, what we realized is, yes, they used to take the photographs, and every photograph had the background, the artist diagrams. Along with that, there was a message. So even though they may not have concentrated on the time, whenever they just go back and see those images, the message of the glaucoma is yet conveyed. So that is going to last for a long time, and it remains as a memory and also an awareness program. And we didn't stop at this point of time. Unfortunately, in 2021, we could not do this exhibition because of the COVID restrictions. And 2022, we again started this exhibition, and again, it was a very hit. So we went on to publish this in our state journal so that many people get to know about this exhibition. Our idea was just to encourage people to think an out-of-the-box idea to create the awareness, because whatever the amount of time, money, whatever you are spending, that should be very, very fruitful. We submitted this to the World Glaucoma Week awareness video platform, and this got accepted. And even it won in the local IRSA Film Festival. Thank you.
Can I use this only here? Yeah, this one.
Next, Madam will be talking about.
Oh, this is the wrong presentation, sorry. You've taken the wrong presentation. Put the flash drive here and put the other presentation.
Community.
Today seems to be,
Yeah, community screening for glaucoma, is it viable? We all know it's not a very easy disease to screen because of various factors involved: intraocular pressure, optic nerve changes, visual field changes, gonioscopy. So it's always a challenge to do a community screening, where the prevalence is not very high, but still we need to find the people at the right time. So Madam will be talking about how we can make it viable.
Actually, community screening is a very gray area of this thing. And if you look at the national program NPCB, the word, truly the glaucoma itself was not there at all. And now they're having a certain amount of sort of, that is also there, but there is really nothing about it. And it's a really challenge. We have a huge population. So magnitude, I won't talk because Pawan has already talked about it, but only one word I would say. As on today, the Indians over the age of 35 are 45 crores. And if we take a simple of 2%, that means we are dealing with 90 million people, which is a huge number, and that is only the glaucoma patients. And if you look at the suspects, it's a huge number, and we have reached a level, then we need to really do it. So how do we do it? This cannot be just a government baby or anybody's baby. It's got to be our baby, right? So we'll be talking about this. So exactly what is the screening is, that is a presumptive diagnosis. We want to catch people before they really get it. So the three kind of ways we do it: the mass screening, we do opportunistic screening, and also we do selective targeted. So some people are doing selective targeted. Opportunistic is actually the way it's going on right now, but mass screening is not the gray, I would say, is the darkest shade of gray. So why do we really need it? I think we all know it here, being glaucoma people, that is irreversible visual damage. Therefore, we got to pick up and nip it in the bud. And unless until we do that, we cannot get good results. So what do we get out of it? We get early diagnosis, we can prevent it, we can enhance the quality of life, and also if we save this, we save the working man years, which are extremely important as far as the economy of the country is concerned. So if we can actually put in the head of the people that is the economy which will be affected, then probably it will sit somewhere. So what do we have in the evidence? The worldwide evidence is the Sightsaver study, in which they used 3 methods, IOP, questionnaire, and FDT. The disc was missing, and the thing was that even if you put IOP, FDT, and questionnaire all together, you're getting only 88% sensitivity and specific 57%. It's not really worth it. So this failed, and this was not really worth it. Another study was the Blue Mountain study, in Australia. They used HRT. They found 40% they could detect, but they also had people who were 200 to 400% people who did not have glaucoma were being detected. So again, this was a disaster. So current prevalent methods in India, we don't really have any glaucoma program, but if we say that nothing is happening is also not true. The cataract camps are going on, just cataract camps. Some camps are comprehensive, and some people are still targeting and experimenting, actually flirting with the ideas as to what we can do. As Venkatesh said, we are using fundus devices, we are using this, but there's not concentrated, and it's not as a program. So come to standard cataract camps, the torchlight camps, which practically even non-operating NGOs doing it, and they're doing a torchlight exam, getting cataract patients. IOP is found high. They call them glaucomas. Disc evaluation is usually not done. Second is these door-to-door screeners. And basically, it is the IOP that is the code word. Some people do screen disc, and they find anybody with that, and they take care. So that's a very small number. Out of cataract, if you have it, you have it. But we know people are far beyond that. Comprehensive camps are a good bet. At least they are seeing AC depth. So we are having some idea. IOP, disc evaluation by direct or indirect, depending upon the capacity. And we are flirting with many ideas right now at the moment, actually, using the camera for the camps, for the camps, for the mobile van, for the vision centers. But only challenge we are facing right now is the training of HR, because you use residents, you use fellows. This is a changing population, but we really need to have some people who are focused and only for that job. Getting people for that job is difficult. And in the targeted, what we can do is, what we're doing right now is that vision centers and mobile vans, fully equipped with mobile fundus camera. Venkatesh has shown, and we are having a joint program with the handheld camera, actually, which is pretty good. Along with the FDT doesn't really work, but either an iPad-based or a virtual reality one goes with it. Along with cataract camps, this is another viable way. So what experience world had was not nice. They said it's not really viable, cost-effective. Chinese people said that it is viable, but lots of caveats. It's a full article. If you read that, there are too many caveats, and to me, it did not really look viable and understandable, this thing. In India, we have a model. It was by Dr. John, that but this model is a model-based study. They have taken cost from Eastern India, one of the NGOs or somebody, model from the programs which are in the literature, and based on that, and they've taken prevalence from Chennai glaucoma study. So from that, different, you put a nose, mouth here, whatever it is, we have to experiment, it might work. And what they found was that cost was about 7.25 thousand per patient. And if this model really works, it's good. But caveat here is that will the people be ready to pay? In the rural India, paying population is pretty much poor, is what we see around our area, and which is a large catchment area. But most important point here is, again, HR, cost effectiveness and all is still, money can be managed, infrastructure can be managed. But people who will get trained and who will stay with you is still a huge challenge. So challenges I've already talked about. This is just a slide. I'll move, but what we really need is the concentrated HR infrastructure, a program, a teleophthalmology, stroke, and AI. So can we sit down like this, that, oh, it's too difficult, we can't do it? Not at all. So we need to work. Here, this is our role comes. In this government, probably can't have so much of it, but competent HR, infrastructure, where we provide all these things for the cataract camp, because cataract camps are viable camps. They generate money. So with that money, partly we utilize for this. Only thing is that we are not adding that in the cataract camps and comprehensive camps. It's a strategy. If we have a proper strategy, minimum required this for screening you need to do for glaucoma, then probably we can make it reasonably viable. So what we are trying now, we are experimenting with this. We don't really have a major data as now, so I'm not presenting data, but a van which has got everything. And this van goes for cataract, it goes for a comprehensive screening, but we are getting a lot of glaucoma suspects whom I'll tell you exactly how we are getting back to hospital, because just tell them to come, they don't come. But all the patients who are cataract or actually having frank glaucoma, they are brought back. These are the two fundus cameras that we use, the Remedio and that I like. The camp has the same protocol as van. And this is the AI fitted in the camera. It's a very basic thing as on now. So it's a project that doctors, optometrists are assessing on one arm, AI is doing on the other arm. We'll know result in, I think, an year or two, that exactly what can AI do, and whatever AI is not able to do, the doctor's assessment will be added to that, and then we'll probably have something really worthwhile. So funding agencies, very difficult to find really people. Somewhere down the line, we all have to rise and shine to this thing. Stand alone by anybody is a distant dream. But put together, if we all join together, I think we can do it. Sandeep Buttin says that if we see all the patients and refer them, but when you refer them, they don't come. All those who are sitting here, we probably will know that if we refer 100 patients, 10, 15 will land up, 90% will not land up. That's another challenge. So possible, viable way would be that we advocate to the government that in whatever way you can do it, please start at least that much. All of us get down and train our whatever manpower we have, whosoever we get, instead of thinking that this will stay or not stay, just train somewhere, the person will go and work. We have one program which everybody put together makes one program, and everybody countrywide follows the same program. Maybe like Arvind, people can do that. That's a followable program. And let's have an algorithm as to how can this program and the data by this can be used into a more effective manner. So ACD, IOP, Van Harix, and DISC, if we have these 4 parameters along with a few questions, I think this will be almost 95% CAI. Regarding viability, so it's HR, technology, and this thing, and funding. But if we add one arm, innovation in it, the innovation is innovation actually which will get the screening into an effective mode. So all the innovative devices, and this is what we had not this thing. This is, I don't call it actually awareness, I call it advocacy. So we have trained about, say, 7,000-8,000 ASHA workers across the districts. And it's not one day. They are into advocacy mode because they're living in the villages. So on very regular basis, they're putting in the head this that you have to screen for glaucoma, you are more than 40 years old. So this is one arm which will prepare them mentally to come to hospital, as well as come to camp or wherever is possible to get themselves screened. So with that, all I would say is that best hope is that an augmented comprehensive approach which involves government, NGOs, practitioners, and practically every citizen of this country, only then we can move somewhere. With a proper screening protocol, whatever infrastructure is available, I would say even a short tonometer is not a bad idea if you don't have a good tonometer for the camp. As long as everybody who comes to campus, at least tonometry is done, a disc is seen, direct is pretty cheap, if not a slit lamp. So we do what we can and put together, I think if we put all of them together, we can reach somewhere. Thank you.
Thank you, madam.
So we can't give these beautiful red and yellow capsicums, but we can give this side of things to our people, which are very much available.
I think you rightly nailed. I think it's the sensitivity which is very important for screening, but the problem is many of these put together also you may not have a very good sensitive screening tool, but even if the specificity is low, it's fine. You may have a lot of false positives coming, but at least we may not really miss the true diagnostic glaucoma patients in a camp. So we need to find a way of kind of compiling all this to make our other screening programs. It may be diabetic retinopathy, cataract screening programs, and whatever way we have to reach. And that's where opportunistic screening is very important. I now invite Dr. Mona to talk about how they practice opportunistic screening.
Good morning, everyone. And at the outset, I would like to thank Dr. Madhu for having me here. It's not showing up. Okay, so let's talk about strengthening opportunistic screening. So we already know that glaucoma is the second leading cause of irreversible blindness, which is preventable. And as we just heard, that in both the developed world as well as the developing countries, more than 90% is undiagnosed. Patients are unaware of the disease. And by 2040, it's projected that around 112 million will have glaucoma. And it's high time we start thinking about screening and preventing the disease and catching it at an early stage. So the settings, as we just saw, were a community setting. This can be done for all individuals or only the high-risk individuals. Community-based screening does come with its challenges, as ma'am has very nicely pointed out. The most important being cost effectiveness, and other issues are the lower prevalence and the impracticalities of certain techniques. So recently, it's a good time to talk about this because just in May, the screening guidelines for glaucoma have been published in JAMA by the updated evidence report and systematic review for the US Preventive Services Task Force. And they said, they did a meta-analysis, and they said that insufficient evidence was there to recommend for or against routine glaucoma screening. But here we should clarify that there the screening was only for primary care physicians, not for community and not for the eye care professionals. And the American Academy of Ophthalmology does recommend a baseline comprehensive eye examination at 40 years of age for everyone, and that is opportunistic screening. And then routinely, with increase in age for people with risk factors. So in the future, with better cost effectiveness and better study designs with AI, with teleophthalmology, community-based screening may be a better option, but currently opportunistic screening is the available and feasible option. So what is opportunistic screening? It is the active detection of glaucoma when patients visit clinics and hospitals or when they come in contact with any type of healthcare and we check them for glaucoma. So a simple way would be when they come to any ophthalmologist for a spectacle checkup or a general checkup, optometrists, physicians, diabetologists. We can be innovative, like when they come in contact with their physicians, healthcare personnel, even their dentists. And like we just saw beautifully in the Pondicherry model, we have to be innovative and think out of the box depending on the situation, because India is diverse in many ways, socially, economically, geographically. So simple thing is that, I don't know how many of you would have renewed your driving license. So after 50, you need to do that. And after 40 years of age, you need to give a certificate which includes measuring your eyesight by a registered medical practitioner. This can easily be clubbed with a comprehensive eye examination to detect absolutely any eye disease. So this is one example, and we really have to think depending on the situation. So the advantage of opportunistic screening is that first, it's the patient who's actively involved. They are the ones who are seeking the care, and they are more likely to listen to you. It's readily available, the specialized staff, the equipment, because the prevalence will be more, there'll be a better predictive value. And here the patient is bearing the cost. So there is a low cost to case detection. But then that can also be the challenge, that's the flip side of the coin. So moreover, non-ophthalmic medical facilities are more readily available, accessible, and in greater number than ophthalmic facilities. Now let's shift to, and in developed countries, more than 50% of cases are detected through opportunistic screening. So what do we do at the ophthalmology level? Any patient who comes to an ophthalmologist, like we just discussed, at least tonometry, gonioscopy, and optic nerve head examination should be done, and visual fields if required. And the challenges are there because there are lack of facilities for comprehensive ophthalmic examination. The number of practicing ophthalmologists are more in urban India rather than rural. And there's a non-standardization of examination techniques which may miss glaucoma, especially gonioscopy, because in the Chennai glaucoma study, we found that a significant number of patients diagnosed as primary open-angle glaucoma prior to examination actually had primary angle closure glaucoma. And similar results have been seen in the West also. So how do we strengthen it? We really have to make guidelines and standardized guidelines for a comprehensive eye examination for any person who comes for an eye checkup. And this also, apart from the standardization, it also needs imparting the skills. We have to accept that it is unequal, so we need to give training also. So when we shift to the primary care clinicians and health workers, the challenge there would be that they don't have an ophthalmic infrastructure, they may not have knowledge about the disease itself, and they may think, it's not my field, so why should I bother about it? It's not my problem. But then, as in the, Dr. Jampel in this review recently published, pointed out that they can just ask 3 questions in the history. Have you ever been told that you have glaucoma? When did you last have an eye checkup? And do you have any family member with glaucoma or blindness? Just these 3 questions by their primary care physician, or like ASHA workers also, like ma'am said. They are the ones who are in regular contact with the patient, so they will motivate them to seek further care. So this has to be accompanied by a referral framework for further evaluation. And as we just saw, cataract screening camps are a very good opportunity to screen for glaucoma also. And both are a disease of elderly population. And a significant proportion of those who had undergone cataract surgery in our rural cohort of Chennai glaucoma study had glaucoma. And cataract screening may be the only point of contact with eye care. So the patients who come to our community center for a cataract surgery, 8% of them were diagnosed with glaucoma. And similar percentages have been noted in other parts of the country, ranging from 2.3 to 4.7 prevalence rates of glaucoma among cataract patients. And this is all well said and done, but we need to audit and assess whether it is taking place correctly and what are the drawbacks and how we can make it better. So vision centers, like ma'am and Dr. Venkatesh have said, that we can use them for screening for glaucoma when the patient comes, and they have a very good referral framework supported by teleophthalmology. And in a pilot we found that about 70% of the referred patients at the vision center did come to the main hospital, and 90% of them were diagnosed with glaucoma. And going further into rural India, where you have geographical challenges, we have mobile surgical units which go and do cataract surgery there. So this is always clubbed with a comprehensive eye examinations where we can pick up glaucoma patients as a part of opportunistic screening. So basically we have to, it has a theory of planned behavior or a whole practice approach. It's not only the ophthalmologist or the clinician, they should even involve the team. Maybe even the receptionist can just, tell the patient in the waiting area or their attendant that, would you like to have a glaucoma screening? So you have to address it at each level, break it down at the patient level, provider level, infrastructure, and policy level. So if you look at the patient, he goes through many stages psychologically. He may be totally unaware that there is a glaucoma screening, or he may be undecided. He may be deciding to act, and there's a gap between acting and actually intention to act and actually doing the screening. And finally, once the screening is done, we should not leave it there. They should be recalled for screenings because it is a progressive disease. And we can address the challenges at various levels by increasing the awareness by various innovative ways, by healthcare workers, by increasing better access to the services. At the provider level, like skills training and reminder strategies, patient navigators, and finally, assessment and incentives are important. And basically, we like to increase the awareness in the media by various ways, develop human resources for eye care, strengthen the service delivery, develop institutional capacity, review and assess the impact. And like Dr. Venkatesh and his team just showed that they gave a sapling. We need to nurture that sapling by reviewing and revisiting the program again and again. Thank you very much.
Thank you, Mona. You have really picked up and covered everything. Now I'll request this one, Nikhil, to please share your Arvind model. Sorry, not LVB model, sorry.
Dr. Venkatesh for this opportunity. So I'm going to talk on LVPI's model of glaucoma care in the rural network. So you all know this is our Hyderabad campus, and you may also know that we are present at 3 other cities in India. But that's not all. LVP is present at more than 250 centers across 3 states in the country. And I would like to draw your attention to this map where each sign here, triangle or pentagon, represents one eye health care unit established in the rural setup by the LVPI system. So this is our Apex Center at Hyderabad, and these 3 are the tertiary care centers, and then below them we have secondary care centers, and then we have primary care centers, and like that it goes into the community. So this we call as pyramidal model of eye health care service, which was developed from top to bottom, but actually it functions from bottom to down. So when you go deep into the rural, we have vision guardians which are selected from the community itself, and they do basically awareness, and whoever has some kind of eye problem, they refer to a nearest primary care center. So each of these green star is a primary health care center. There are about 8 to 10 centers attached to a secondary level center, and there are about 20 secondary level care center across these 3 states. So each vision center is operated by a vision technician. They are basically high school graduates, and they are trained for 1 year into one of our tertiary or Apex center into procedures in optometry. So they do basic refraction, they can dispense glasses, and then they do screening for diseases. So when it comes to glaucoma, they do applanation tonometry, they look at Van Herrick's for angle closure disease, and then they do direct ophthalmoscopy to look at the disc. And if there is any suspicion at any of these levels, then it is referred to a secondary level center. So these are our typical secondary level centers, which are basically managed by 20 to 25 people, healthcare personnel as a team. There are 1 or 2 ophthalmologists. They are posted there as a part of their fellowship training for 1 year, and then they are in charge of their center. So they take care of comprehensive ophthalmic examination, basic diseases including cataract. This is a typical OR setup, a basic OR setup where cataract surgery can be done. And then this we call it as a vision village vision complex, where 100 guardians or typically 10 centers and a secondary eye care team takes care of a considerable number of population. Now if somebody has a difficult problem, somebody has glaucoma, somebody has congenital glaucoma or some other condition, then they have to send patients to the tertiary or Hyderabad center. So I agree that the linkage has been well established, but then still there are many challenges. So when I started visiting to secondary centers, I realized that even if you give them a clear pathway that you need to go to here, many of them are not able to go because of various reasons. Even in rural, they don't have sufficient manpower to take them, or they may not be able to afford. Some of them are physically not fit enough to go there, and various reasons like that, and they are not able to go. So till now the linkage is established only unidirectional. So I thought, can we put a vertical stream to this? So till now what is done is a horizontal system of eye care which has been established into the deep rural communities, and then I thought, can we add a vertical stream, which is possible for very few conditions because you need certain characteristics of the condition. It was done earlier only for cleft lip and cleft palate surgeries. So I took an experiment and I selected 4 centers on all sides of the Hyderabad, and I started visiting 2 days in a week into a center. Now there is an ophthalmologist there. So the ophthalmologist is typically seeing about 4 to 5 patients of glaucoma. So they have given a guideline, they have done a basic training, and they have asked to do a comprehensive ophthalmic examination. whoever has occludable angle, they do YAG iridotomy and then dilate, see the patient, see the disc, see the fundus, do the visual fields, and then basically stratify patients into one of the three categories. So first category is simple, which they can manage. Second, they can manage with or without a help, maybe putting teleophthalmology into practice. And the third category are more difficult patients which are pooled for my visit. And when I go there, I see those patients. Typically on the first day, I'll see the patients. There are about 80 to 100 patients, hardcore glaucoma patients, see there. And then next day you operate in that setup. And it is possible. In that basic setup, it's possible. And it also gives an opportunity to have 1:1 teaching to the fellow as well as to the optometrist and run the system. So to show you some examples, like this was an one-eyed patient, elderly. He could not even walk. He had severe osteoarthritis. Somebody had to bring him in a wheelchair. One-eyed, very advanced glaucoma. I did combined surgery there, and he got a significant vision. This lady had nanophthalmos, presented with acute angle closure. One of the visit I did YAG-PI. Next visit I did cataract surgery. And there she was managed. This patient had a bleb leak. I did simple autologous blood injection, and all these conditions settled there and there itself. Then we looked at the outcomes of this model in a formal way. So I took 231 new patients of glaucoma who presented at one of the center, and this is the distribution in the categories that I showed. Nearly 1/3 of them were into a very advanced stage or difficult categories. And when I looked at the result, it saved a significant referral, significant cost to the patient, and it added significant teaching value to the ophthalmologists there as well, because in almost 50% of patients I could contribute either by changing the way they were managing or operating or assisting in the surgery to the fellow. While doing that, I realized that SICS IOL trabeculectomy is more practical than doing phacotrabeculectomy there, and then I modified the steps, made the steps more standardized. So now this is my favorite technique, where I do every step in the same manner. It is standardized and it is easy to teach. So this is outcome of one of the patient who had pseudo-exfoliation glaucoma and had a nice diffuse shallow bleb with good control of IOP. This is one of the surgery done by a fellow, not necessary glaucoma fellow. I taught the surgery to them, simplified, standardized, so they know exactly what is to be done. And I looked at the outcome at 1 year, and the outcome is up to 92% survival at the end of 1 year with up to 1 topical AGM, and this is without antimetabolite. So now currently I am looking at usage of antimetabolite and see how does this happen. But the most interesting here are, there are 2 lines. One is survival of surgeries which I have done, and other one is survival of surgeries done by a fellow, not necessary a glaucoma fellow. 40% of surgeries done by them based on their competency and the difficulty of the case, but the outcome is comparable. And that's the most important message. I have put all the steps and video in detail into this article, which is free for all members of any glaucoma society, and if whoever is interested should go through this. Now this surgery we are following across the network. All glaucoma fellows are doing every surgery with the same step. It is much easier for them, and the outcomes are predictable. The steps, the post-operative treatment regimen is all standardized. There are also challenges. This model is working well now, but there are challenges. During COVID, we thought that what will happen, some patients could not come, but post-COVID, the numbers have regressed to the mean. We realize that we need to upscale the resources. So now, after this is started working, now every faculty in LVP is going to a rural center once a month, and all my colleagues are implementing this model into all our rural network and doing glaucoma care. The stratification of diseases, the disease that I showed is not very linear kind of stratification, and everybody may not fit into one of the category. But this is, I thought that this is a more practical way of doing things. So what I have done is, if you see this, this is just says that post-iridotomy occludable angle, but it may be a plato iris syndrome, or if a patient is monocular, or somebody has side effects of treatment, they're put into there so that when a faculty is visiting, those patients are pooled. So now we tag the patients into which of the category these are, and accordingly the receptionists are trained to give appointment with the faculty when they are coming, and that's how we are doing. Now I did some experiments regarding the diagnostic ability of screening tests, and as we were talking earlier, so I looked at these 3 common tests which we are looking for screening, and they show a good specificity, though the sensitivity is less. But the problem is that the prevalence of the disease is low in the community, and that's the whole big problem. So if you look at the positive predictive value, that's really low, even though the specificity is quite good. So then I did some simple experiments. One is that you just modify the cutoff of Van Herrick system. So if you want to rule in the disease, you made it more strict. Instead of cutoff of grade 2, we make it grade 1, and see the specificity has increased, PPV has increased. Similar, if you want to rule out, you make it more lenient cutoff, and your sensitivity and NPV has increased. The other strategy is to do a test combination strategy. So we did a combination of simple biometry and Van Herrick, and found that the predictive value is quite high and at least as good as all these sophisticated diagnostic techniques. So there are many challenges. There is no single reliable diagnostic test for glaucoma. If you screen patients, what do you do for the screen patients? There are several rural-urban differences, which Mona also said just now. But I think we can do this. There is possibility of adding a vertical program. Agreed, I could do this because of the existing horizontal network, which is a very big thing that LVP has done, otherwise it was not possible. But still we can think in this direction, because most of the decisions in glaucoma are clinical, and we rarely need these sophisticated instruments in each and every patient. It can be managed, so we say that it can be managed at a rural center by traveling, say, just 2 days in a month. You can make a large difference to the people. So these are the 5 things Madam had put when she put up these course together. And I think by this model we may be doing something good at these 3 levels, but still there is many things to be done. Now this awareness we are even doing in rural centers in World Glaucoma Week, but it's not sufficient, because I look at the prevalence, hospital prevalence of glaucoma at each of these centers. It is still 50% of what is supposed to be in the community. So that means we are still lacking there. And maybe we need to do a brainstorming, we decide, make more guidelines, decide further path, unite, and make things more clear, and decide what exactly we are going to do, and that may make difference in future.
Thank you, Nikhil. Really, it's a beautiful model and truly workable model. Now I'll request Dr. Venkatesh to get into the innovations put together as to truly how can we reduce the training, how can we get the more sensitive and more specific things with, as Nikhil showed, not really in Humphrey, something cheaper and something like that, and better results.
Thank you, madam. I think it's a very important course. It's very rare to have a course like this in all India, but it's so important that we'll have to think how we can make the screening better, and there's no better way than doing a good opportunistic screening. Wherever we get an opportunity, we need to get and see how we can diagnose more glaucoma much earlier. Okay. So I'm going to share some of the innovations we have done in the recent past back at Pondicherry, where I practice glaucoma. Some of my colleagues, Dr. Pawan, Kavita, they have all been in the background. And we know this is a kind of problem we have, the distorted map of blindness. You would have seen several years back, so I just want to recollect. So this is how the practicing or the ophthalmologist who can take care. When you see that, the whole map shrinks in certain places, including India, Africa, rest of developing world. So there's a lot of scarcity in human resources. So we need to kind of think about a better way in all these things. But the best at this point of time to really focus on the high-risk patients and also on doing a good opportunistic screening. So I'm going to share with you some of the things. So I'm just going to share with you this family, who came some time back. So this is a mother of our insurance expert. Her name is Devi. She's sitting right behind. And she brought her mother, and mother had a POAG, definitive POAG. And then we asked Devi, can we see all her siblings? And you see them all sitting there. So she said, today I have a housewarming ceremony, and they have all come from their native villages. We said, you get them all in the afternoon or around 4 o'clock. So they all are there. You can see all the 4 sisters. 3 had glaucoma, except 1. So out of the 4, 3 had glaucoma. And we had one more brother who was examined the next day because he had gone out to get some dinner or something, arrange something. So next day we saw him. Luckily, he also didn't have. So 3 out of 5 had glaucoma. So I'm sure in your practice you are seeing several families. But the point is we kind of do an ad hoc screening. Whenever we tell it's possible, some people bring, some people don't tell their siblings. And interestingly, you'll see a lot of rivalry between siblings these days. They don't even tell their siblings, right? I ask them, can you tell your brother or sister? Sir, it's been a long time since I spoke to him. Why are you worried about him? You worry about me who is sitting in front of you. So these stories are really kind of little sad. So we thought we should do something better. And that's when we kind of started this family screening model. First, it was more like a paperwork like this. We have these case records where we enter all the information, and everything we entered into a software. Okay, like your brother, sister, how many, we take their contact numbers. So the counselor, we put an additional counselor to do this job, and everything was kind of here. And we used to give a sibling screening card to the proband. We write a sibling's name, and then we ask them to just pass this card to the sibling whenever they meet them or their children, and then we enter into the program and we start tracking them, reminding them. But even this wasn't very successful. So we had to think even out of the box. So when we had EMR, we had incorporated the same software into our electronic medical record. So automatically when you take history, it is all uploaded there, and the counselor has to take their contact numbers, and once their contact numbers are done, they get an automated SMS immediately and a voice message, because a lot of people don't even read messages these days, like they are into WhatsApp. So it's difficult to connect through WhatsApp. So they get a voice call, okay, that your sibling was screened. I mean, they have a doubtful glaucoma. It'll be nice for you to get your eyes tested. And we kind of worked on this, and we know how the prevalent of angle closure in India and South India. So now we worked on something where everything is kind of automated. See, we didn't want this to happen ad hoc. It was not happening. So we wanted to make it like a system. So now this family screening has become a part of the system. So every day we screen close to 20 patients in Pondicherry alone who are family members. And through a project, we offer a free screening for them, the basic screening. Rest of the investigations are done at a later stage. But doing something like this, in your daily practice, you can start family people coming. Otherwise, it will be like World Glaucoma Month or week. When we do those family screening, it's not going to really help. We may reach maybe 10, 100 people. But if you want to reach thousands of family members, you may have to do something like this. If you are interested, we can definitely help you. So there is a process for it. So this is the message which goes to them. And then we track them. We give missed calls, and then it's like something like getting a consent for them to send messages about glaucoma. and then we get them for examination. And this has significantly increased the way at least we touch the family members. From here, I'll just quickly go to vision centers. No, you know the vision center model in LV Prasad. So we have network of 100 plus vision centers now. So this is how they function. No, they are in a semi-urban rural area. Two optometrists are the vision technicians who are well trained in the base hospital do this. So one is a person who registers and then takes care of the optical and medical shop. The other person does the comprehensive eye examination. So she's a trained optometrist. And these two people, they roughly see 25 to 30 patients daily in a vision center. And you can see they do comprehensive eye evaluation. So they have a applanation tonometer. They can visualize the fundus with 90D. And wherever they suspect posterior segment, any issues, then they image with a fundus on phone. This is a slightly older version, it's an older video. Now we have attached the fundus on phone right in the slit lamp. So you don't have to move every time. They just have to move the slit lamp or the fundus on phone. And it seamlessly, it is also attached to the EMR. So they don't have to remove the cable and upload the images. The images are automatically transferred into the fundus photo area of the EMR now. And then they get a teleconsult with a resident, usually a senior resident, second or a third year resident. They are posted monthly for doing this teleconsult, and then they keep changing. So what usually happened is we get posterior segment diseases being referred, but many may be false positives also. No, there are a lot of dissuspects and patients who are coming, but still the true cases were being kind of found. So then we decided that we are still missing when they see the 90D and they are taking images wherever they suspect posterior segment disease. So we thought, can we image every patient who needs a fundus image? So anybody above the age of 35, 40, can we image and see? So we did a step wedge cluster randomization in 4 of the vision centers which you see. So 50% we did standard of care. Standard of care is whenever you need a fundus photo, they'll take. The other was routine photography. No, the other group, they did routine photography for the intervention group, and they all had a teleconsultation. So what we found was between the control and the intervention, there was a significant increase in the posterior segment diagnosis, especially in diabetic retinopathy, macular edema, glaucoma suspects. You can see 16 and 38. No? So there was a significant increase in some of the cases, and also we found that the significant increase was in the non-urgent referral, no, which is like a mild NPDR, moderate NPDR, early glaucoma changes. The urgent referral, no, already if they had a visual disability, it wasn't big difference. But the non-urgent, no, which are the earlier cases which we want to find and start creating awareness or start treating them, kind of significantly increased between these two groups. So we went on to publish this work some time back, and we said that it's good to fundus image, no, because technicians are good, but they can miss some of these conditions. So it's good to image, and these images will really help the teleconsultation part. Finally, I'll touch upon the outreach. I'm sure many of you do outreach. We have been doing outreach for several years, but it's been always bothering that you want to piggyback, but you're still not piggybacking. You're still focused on cataract. At the end of the day, you're bringing cataract in buses and then forgetting other conditions. So we thought we should go beyond. So at least now in Pondicherry, you can see camps happening in this way. We have electronic medical record in iCamp. We have low-cost technologies being used in iCamp. So you can see the laptop for all the entry. There's a handle slit lamp between the doctors to share. And the optometrists, they do refraction. And then they get a eye care tonometry. The pressure is, again, it's seamlessly connected to the EMR. It goes to the EMR. And then you can see we use the Bosch camera here because it's very easy to do in a campsite than on a fundus on phone, which is a little heavy to hold. And then the images are transferred again to the electronic medical record so that you know how difficult it is to see a fundus in a campsite, the hygiene of the patient, the environmental conditions around you. So even if you give a direct ophthalmoscopy, indirect, it doesn't happen. At the end of the day, they say that we didn't see any diabetic retinopathy or glaucoma, which was bothering. So this model, again, we did a trial comparing the traditional eye cams in Aravind versus the novel method of using eye care and fundus photography, EMR, and we found again a significant increase in the diagnosis of posterior segment disease. So this is, again, we are trying to really piggyback on the cataract model so that now we get more referral of these conditions. And the point is not just referring, we need to even close the loop. Like Madam was mentioning, some of the advanced cases, even we tried to bring them with the cataract patients, do a combined surgery or a trabeculectomy, or maybe a laser for PDR, because now we have the Chief Minister Comprehensive Insurance Scheme, which is covering all this. So they allow us to bring the patients and do the treatment. So the only issue which we saw was the slight increase in time, which is well understandable. It takes 1.5 hours more than the traditional, where you're just putting torchlight or doing a shear stonometry is definitely different. But we understand that it may become cost effective. We are working on that study also to see whether it is cost effective. But once you start doing as a routine, I'm sure this time would also come down, because it's with practice we see people do brilliant fundus photography, and then the flow also becomes much smoother. So this, again, we took into a publication during the COVID time, where we did this trial before COVID, and we concluded by saying that use of digital fundus photography in a novel eye cam resulted in increased detection and referral of posterior segment disease. So with this, I'm just going to finally touch on the work which we are just doing. I got the results very hot out of the press from the team Remedio, which I'm working with, and we are working in 6 of our vision centers. Of the 15 vision centers we have in Pondicherry, I'm sure you know their offline AI for DR is working brilliantly, and now we are closely working with them in the glaucoma part, where you take an image, immediately the software would tell you whether it is a sufficient quality or insufficient. Insufficient, you have to repeat the image. If it is sufficient, then it crops the area of interest like this. And then there are 2 things which immediately happen. One is the segmentation, and the other is the classification. Segmentation, more, it looks at the disc margin, the cup margin, and the next level, it will also look beyond that. What is the recommendation for referral? It will look into the, and then it will give you a PDF printout like this, and say, within the disc and beyond disc, what it looked for, even a subtle RNFL defect, peripapillary atrophy. So it is trained to look into all these things beyond the cup to disc ratio, and then like you see the subtle defect here, which the map picks up. And then it gives you a PDF record whether to refer or not. So what we did was, so we did this trial a few months back. We looked at 299 patients with the image-based diagnosis of glaucoma for referral warranted glaucoma. When it referral, we are talking about both glaucoma and the disc suspects. And it was a comparison between artificial intelligence and the teleconsult doctors. The vision center doctors are teleconsult doctors who are the senior residents. Now they are second year, at the end of second year or third year, or sometimes even the fellows who have just joined with us do the teleconsultation. So what we saw was, this is just to compare between the AI and the VC or the teleconsult doctors, the sensitivity was 73% and the specificity was as good as 98%. And you can see the positive predictive value and the negative predictive value. But the point what we noted was, in the vision center doctors, there were more of disc suspects than glaucoma. So then we got a subset of patients who were referred and who came to the base hospital. The patients are still coming, but we were able to analyze some 70 patients referred to base hospital from vision center. Now, and then we compared between AI and the teleconsult doctors with, after all the investigations like HFA, OCT, the expert doctor diagnosis. Now we saw the correlation between these two. And if you see, like between the AI and the expert doctor diagnosis, it had a very good sensitivity and specificity, more than 90%. But if you see between the VC doctor or the teleconsult doctor and the expert doctor diagnosis, you can see the specificity is slightly low. That means they were, the healthy patients were not detected properly. They're saying a lot of people as disc suspects and referring them. So what we saw was, even if they are trained doctors, meaning they have their MS or whatever degree, but they are under training, like residents here, they tend to overdiagnose glaucoma, in myopes or asymmetry in cups or asymmetry in disc sizes. But the AI is able to exactly say, this cup is because of asymmetry in the disc. This cup is a physiological cup in a myopic patient. The rim is good, no other features. So somewhere it is kind of improving the training of the teleconsult doctors also. So when they see this, when they see the RNFL defect, when they see the map there with the heat map, with those things, they also learn, and we found that the AI diagnosis was pretty much more reliable than even the teleconsult ophthalmologist when compared to the expert doctor diagnosis. So when you talk about certain glaucoma, you can see the numbers there. The sensitivity was as good as 96.4% for the AI, and it was 53.5% for the teleconsult doctors. So somewhere there is a major role for this in the future, and with that small result, we are still working on this. We are working to present at WOC and then even publish it. We found that the AI detects certain glaucoma with a very high sensitivity than the teleconsult doctors, and reduces the number of over-referral, which is very important for us. When you say a disc suspect, a myopic disc and all that to the base hospital, you are unnecessarily wasting their resources, time, and your time and resources in the base hospital, which can be definitely improved by doing this. And AI can potentially be used as a clinical decision support tool to improve the diagnostic consistency of the VC doctors. They can also look into it and improve their knowledge also about disc and the changes around the disc. And the AI performance to detect the referral warranted glaucoma when challenged with the fundus images was very promising when compared against a specialist with a full examination. So this is the interim results which we just got, but we are still working on all the other 299 patients to come to the base hospital. But again, it's a challenge to get them to the base hospital. Many of the normals are not ready to travel, so we are still working on that. But the point is, AI at this point of time, when we see and compare with the expert doctors, it's really doing a very good job. And we did even a pre-pilot before that in the base hospital. We found almost the same results. So there seems to be a very promising future to also improve the screening when you use something like this. So if you have a trained technician doing an imaging in a community, and then the software says refer versus no refer, it would be more than enough, because you have a reasonably good sensitivity and specificity. I think again, with this, I take this opportunity to thank Madam for conducting this course, and if you have any questions related to this, we'll be happy to take. Thank you.
He's very good with fundus pictures. He takes excellent pictures, and that's it.
The camera which Madam was showing you, called the iLight, is basically a refurbished plastic. It's made of a refurbished plastic and Samsung phones. It's a company in Korea who makes that, and they are trying to partner with a lot of people in India to make the screening better. They have AI algorithms also, which Madam was showing you, to detect diabetic retinopathy and glaucoma and other changes. It's kind of very less expensive, but a very good tool.
It's trash to treasure, but it's more difficult than Remedio. Remedio is so much easier. Remedio boy does a wonderful job that he goes to outreach. These cameras we have given to vision centers. And those people, the yield, what you were saying is that we haven't compiled really as yet because it's new and the lots of images were not gradable to start with. The image quality has now improved, and the detection has increased. People who are good, significant amount of DR and glaucoma is being referred to hospital now.
Any questions?
The project is trash to treasure because they're using everything recycled. Even the phones which have been given away by people, exchange programs, and those are the kind of phones. I think no questions. I think then we are done, right?
Yes, sir.
Pawan, anything from your side? Nikhil, Mona, anything you guys want to add that you were not able to say then because of the paucity of time? So now we have another 10 minutes. My message is loud and clear that whatever is possible, do. Nothing is, if we keep on waiting till that everything is available, the cows will come home. So therefore, even something like a torchlight, Smith's test, or the Van Herrick's, if slit lamp is there. Otherwise, Smith's test is good. Shear tonometer is also good as long as something is done. Direct ophthalmoscope is really not bad if they're only plain cataract camps. Only one or two people are going. Everybody doesn't really have resources. But as long as the mind wants to look at it, that's worth it. Ideal ways we have already talked about that this is the way we can do. And innovations would be probably the key finally in the end, because we will not have so many doctors. We will not have so many trained optometrists also, because another challenge we are not able to decipher or not. Optometrists now want to go their own kind of practices, so there are very few. Like Nikhil has those vision technicians with 1 year training, but anybody who has a government kind of a degree diploma in hand is setting up practice. So, and there will be multiple other things with that. So we really have to think as to where we are going and what do we need to do. In the forum, I can't speak of unethical practices. That's the other thing.
Yeah. I think we'll hand over the stage to the next team.
So the
Thank
next
you.
people, if they're there, they can have the stage and use the extra time.